Pregnancy-induced hypertension, PIH, is hypertension that occurs after 20 weeks of gestation in women with previously normal blood pressure. The broad classification of pregnancy-induced hypertension during pregnancy is gestational hypertension, preeclampsia, and eclampsia. Now, to better understand this subject matter, I am joined by consultant, obstetrician, and gynecologist, Dr. Michael Agbaji. Thank you for joining us, Doctor.
Yeah, nice being on your program. Thank you for inviting.
Let's start with this one. What is pregnancy-induced hypertension?
Generally speaking, when we talk about hypertension, this is a condition in anybody now where you have elevated blood pressure, when you have a systolic blood pressure greater than 140 over a diastolic of greater than 90 millimeter of mercury. That's where you hear 140 over 90 millimeter of mercury. So in any patient at all, regardless of whether they're pregnant or not, that gives you a diagnosis of hypertension. Now, having that same value in a woman who is pregnant, either it is the first time it's been recorded, that's what you can say gestational hypertension is. In a woman who has previously been normotensive. You understand? You do have various conditions. For instance, a woman who has hypertension before pregnancy, and then she gets pregnant, that is a different definition entirely. All right. So in that condition, you can say she's a chronic hypertensive in pregnancy. Okay. But for a woman who is achieving pregnancy and the first time she's having an elevated blood pressure, it is noted in pregnancy. That's what we call gestational hypertension.
Let me come in here. Talk to us. What's the relationship between PIH and preeclampsia?
Yeah, so preeclampsia now is a woman having gestational hypertension with what is called proteinuria. Okay. Now, let me see how I can try and put it in, not so technical terms. So if you have a woman who is hypertensive, or generally anybody who is hypertensive, the elevated blood pressure has an effect systematically on the patient. It can be with regards to the brain, it can be the heart, it can be the liver, it can be the kidney. You understand? So the raised blood pressure can damage those organs. So with regards to preeclampsia, you have an elevated blood pressure having a systemic effect, and you are seeing the evidence of that systemic effect on the kidney. And then the kidney begins to malfunction, so to say, to such an extent that the kidney can no longer reabsorb protein. The function of the kidney is basically to excrete waste products. Proteins are not waste products from the body. So part of the function of the kidney is to reabsorb that. So when you have an elevated blood pressure that is damaging the kidney to the extent that it can no longer reabsorb proteins, you now have proteinuria. So when you have a combination of the blood pressure with proteinuria, that is what we call preeclampsia.
Well, talk to us about the risk factors.
Okay, so pregnancy-induced hypertension, the risk factors for this are you have people, most times we look at the two entities together, because a patient who develops pregnancy-induced hypertension is at risk of it progressing into preeclampsia. So I would like to look at the two of them as the same entity, because the same risk factors are bound for both of them. You have women who are getting pregnant for the first time, primigravida. You have young age in the women who are getting pregnant. So you have a 16, 17, 18-year-old girl who's getting pregnant. She's at risk of developing gestational hypertension / preeclampsia. You have people who have family history. All right. You have somebody whose parents were hypertensive or diabetic. Such patients who are at risk of developing hypertension in pregnancy. You have those who have coexisting medical conditions, that predispose them to this, diabetes and non-diabetics, people who have non-renal disease, who are now, getting pregnant. So those are some of the risk factors associated with gestational hypertension. Also, you could have women who have multiple pregnancies, advanced maternal age, a woman who is carrying twins or triplets, either spontaneously or from IVF, and a woman who is, getting past the age of 35 or 40. This category of women are increased risk of having medical disorders in pregnancy, gestational hypertension, preeclampsia.
So how exactly do we ensure these women, that's the people who are at risk, are well managed?
Okay, so part of, taking care of pregnant women, the antenatal process, part of the purpose is to stratify patients, high risk or low risk patients. A woman who develops hypertension or preeclampsia can be classified into a high risk patient. Now, despite that, in situations where treatment is available, where treatment is, carried out with these patients, the prognosis is quite good. That there are medications, there are antihypertensives, oral medication that can be used, either singly or in combination with other medication that can make controlling the blood pressure easier. The management of these patients is also better when you have what we call a multidisciplinary approach. That means that you have either the gynecologist or the obstetrician managing, you involve an endocrinologist, you involve a cardiologist, so 3 heads are better than one kind of situation. The control of the blood pressure is a lot better. The outcomes are a lot better. Now, despite the fact that you have drugs and things that you can do to control it or to manage it, the ultimate cure, as it were, for gestational hypertension or preeclampsia is to deliver the baby, because it's more saying that it is the stress of pregnancy that is causing the gestational hypertension. The hypertension has a risk to the mother and to the baby. So despite the fact that we have medication and treatment for the hypertension in pregnancy, the only cure is to deliver the baby as soon as as early as possible, as soon as it has reached the age of viability. So it would depend on how well the woman's blood pressure is controlled. If it is just straightforward gestational hypertension without proteinuria, you can push maybe 38, 39 weeks or thereabouts and induce as soon as the baby is, matured enough. But if the blood pressure is poorly controlled, despite all the measures you are taking, there's the option of outrightly terminating the pregnancy if the woman's life is at risk. You understand? So even if the baby is not matured enough, and you're seeing signs that, look, if we continue with this pregnancy, the blood pressure can damage the kidney, such that after pregnancy, the woman may now develop renal failure. It's better to terminate the pregnancy and, allow the woman recover from the condition, her kidneys recover, and, she gets better globally. So those are some of the things that prognosticate how well patients can be, how to manage them and the patient's condition.
So away from that, are there other symptoms we need to watch out for?
So we all know, allow me to say, we all know hypertension in its early stages has no symptoms. It may be asymptomatic. That means you have somebody with an elevated blood pressure, they're walking around, no issues. But when the effects of the blood pressure on the systems now start to manifest, so you may now start to see the patient complaining of headaches. That's one of the most common things. You find the woman in pregnancy is complaining, I've been having this headache. I'm finding it difficult to sleep. I feel uneasy. Now, when it starts to progress to preeclampsia, just as I've said, is when there's evidence of end organ damage to the brain, to the liver, to the heart, to the kidney. That's when you now start to see some specific things. The headaches, sign of damage to the brain. The woman may start to see flashing lights. She may have blurry vision. It's sign of damage to the brain. She may develop heart failure, because the heart is malfunction, is under a lot of pressure. You may start to have pain, towards the right side of her upper abdomen. It shows that there's damage to the liver. Then biochemical evidence is when you now run some blood tests. You check some of the liver enzymes, they're markedly elevated. You check the kidney function. You're seeing the things what we're calling the proteinuria. You're doing an electrolyte, urea creatinine, and you have deranged parameters. So these are some of the things that we will see clinically that would suggest that you have a patient who is hypertensive and signs of complications have started to set in.